Hello and welcome. Today we will discuss drugs used in male infertility and sexual dysfunction. This is an important and highly clinically relevant topic because infertility and sexual dysfunction are extremely common problems encountered in clinical practice. Yet they are often surrounded by misconceptions, psychological stress, social stigma, and inappropriate self-medication. So, let's start. The learning objectives are shown. Please take a look. Infertility is generally defined as failure to achieve pregnancy after 1 year of adequate unprotected sexual activity. Notice the graph on the slide showing cumulative conception rates over time. Many healthy couples may require several months before conception occurs naturally. Therefore, reassurance and counseling are often important components of management. Infertility is not always pathological. However, when conception does not occur after prolonged regular unprotected intercourse, evaluation becomes necessary. Another important point is that infertility should never be approached as only a female problem or only a male problem. Both partners require evaluation because fertility depends on coordinated reproductive function in both individuals. You can see common causes of infertility listed here in both genders. In females, causes include cervicitis, pelvic inflammatory disease, leiomyoma, polycystic ovarian syndrome, anovulation, and endometriosis. In males, important causes include oligospermia, azoospermia, androgen deficiency, retrograde ejaculation, erectile dysfunction, and premature ejaculation. Notice that some causes are hormonal, some are anatomical, some are neurological, and some are psychological. This distinction is clinically important because pharmacological treatment depends entirely upon identifying the underlying mechanism. For example, giving testosterone to a patient with infertility may actually worsen fertility because exogenous testosterone suppresses gonadotropins and spermatogenesis. Therefore, infertility management requires mechanism-based reasoning. Management of infertility in either sex is similar and begins with reassurance and counseling because anxiety and stress themselves may worsen reproductive function. Pharmacotherapy should always target the underlying cause. Sometimes the pathology lies within the reproductive system itself, whereas in other cases systemic disease, endocrine dysfunction, obesity, medications, or psychological disorders may contribute. In some patients, surgical interventions or assisted reproductive technologies may become necessary. The key clinical principle is individualized treatment. Infertility is not a single disease but rather a symptom resulting from many possible underlying abnormalities. Now let's take a committed approach for men. Before discussing infertility drugs, we must first review the hypothalamo-pituitary gonadal axis. GnRH released from the hypothalamus stimulates the pituitary gland to release LH and FSH. LH stimulates Leydig cells to produce testosterone, whereas FSH supports spermatogenesis through Sertoli cells. Testosterone exerts negative feedback inhibition on the hypothalamus and pituitary gland. In addition, some testosterone undergoes aromatization into estrogen, which also contributes to feedback inhibition. This is extremely important because many infertility drugs work by manipulating this feedback system. For example, clomiphene blocks estrogen-mediated negative feedback in both sexes, thereby increasing gonadotropin release and gametogenesis. Understanding this axis makes the pharmacology much more logical. This slide summarizes pharmacological approaches toward oligospermia. Clomiphene citrate, gonadotropins, and aromatase inhibitors such as letrozole and anastrozole may all be used depending upon the underlying mechanism. Patients with androgen deficiency may require gonadotropins such as HCG, FSH, or HMG. An important principle is that male infertility treatment often aims to increase endogenous gonadotropin activity and spermatogenesis rather than simply giving testosterone. This is because spermatogenesis depends upon intratesticular testosterone and gonadotropin signaling. Clomiphene is a selective estrogen receptor modulator, or SERM. It contains two stereoisomers, N-clomiphene and Zu-clomiphene. N-clomiphene has predominantly anti-estrogenic and pro-androgenic activity, whereas Zu-clomiphene has more estrogenic effects and a longer half-life. Mechanistically, clomiphene blocks estrogen-mediated negative feedback at the hypothalamus and pituitary gland. As a result, GnRH secretion increases, leading to increased FSH and LH release. This stimulates spermatogenesis and testosterone production. A similar mechanism stimulates ovaries when clomiphene is given to females to treat infertility. Thus, the drug stimulates endogenous reproductive pathways in both sexes. Clomiphene is used for induction of gametogenesis in both sexes. In men, it improves spermatogenesis. In women, it promotes ovarian follicular development. Adverse effects include nausea, headache, weight gain, changes in libido, and gynecomastia. Excessive gonadal stimulation may produce testicular enlargement in men or ovarian cyst formation in women. An important concept is that clomiphene works best when the hypothalamo-pituitary gonadal axis is still functionally intact. Human menopausal gonadotropin contains both FSH and LH activity, whereas HCG primarily acts like LH. Pulsatile administration stimulates testosterone production and spermatogenesis in men and follicular development in women. These agents are particularly useful in infertility secondary to gonadotropin deficiency. Because these hormones are peptides, they require subcutaneous or intramuscular administration. Adverse effects include injection site soreness, acne, and changes in libido. Anastrozole is a nonsteroidal, competitive, long-acting aromatase inhibitor. It prevents conversion of androgens into estrogens in extragonadal tissues. It is especially useful when estradiol levels are elevated. It may significantly increase testosterone levels. Adverse effects include headache, bone pain, joint pain, hypercholesterolemia, osteoporosis, and arthritis. Aromatase inhibitors remind us that estrogen physiology is also highly relevant in men. Letrozole is also an aromatase inhibitor. It prevents conversion of androgens into estrogens, especially within adipose tissue. Its duration of action is even longer than anastrozole. This is clinically useful in obese men because obesity increases aromatase activity and estrogen production. Elevated estrogen then suppresses gonadotropin secretion through negative feedback. By reducing estrogen formation, letrozole increases gonadotropin activity and endogenous testosterone production. Adverse effects include edema, dizziness, hypercholesterolemia, osteoporosis, and allergic reactions. Bromocriptine is a dopaminergic ergot alkaloid. It stimulates dopamine receptors and thus lowers circulating prolactin levels. Hence, it is used in infertility secondary to hyperprolactinemia. Hyperprolactinemia suppresses GnRH secretion and may therefore impair fertility and sexual function. By reducing prolactin levels, bromocriptine restores normal reproductive endocrine activity. Adverse effects include hypertension, hallucinations, confusion, abnormal movements, and hepatotoxicity. Retrograde ejaculation occurs when semen enters the urinary bladder instead of being expelled through the urethra, as shown in this diagram. This condition may occur due to autonomic dysfunction, diabetic neuropathy, surgery, or drug-induced sphincter relaxation. Treatment aims to increase bladder neck sphincter tone. Drugs such as imipramine and pseudoephedrine increase sympathetic tone and improve closure of the bladder neck during ejaculation. Imipramine is a tricyclic antidepressant. This psychiatric drug is used for a reproductive disorder because of its autonomic effects. Please check the lecture on antidepressants on this channel for details of this drug. Here it is described briefly. In retrograde ejaculation, it is useful because it possesses alpha-1 adrenergic agonist activity that increases urethral sphincter tone. As a result, semen is redirected through the normal antegrade pathway. However, because it is a tricyclic antidepressant, antimuscarinic adverse effects are common, especially in elderly patients. Sexual dysfunction is a broad term encompassing multiple disorders affecting libido, arousal, erection, ejaculation, and orgasm. Many cases have psychological or psychiatric components. Declining testosterone levels may also contribute. Counseling is therefore often extremely important. One major misconception among the public is the belief that all sexual dysfunction requires hormonal therapy. In reality, Endocrine causes represent only one component of a much broader biopsychosocial framework. However, many cases of sexual dysfunction in men are secondary to organic issues, such as increasing age, diabetes mellitus, hypertension, cardiovascular disease, neuropsychiatric disorders, or drug-induced. This slide integrates physiology and pharmacology beautifully. Sexual desire, arousal, erection, ejaculation, and orgasm all involve distinct central and peripheral pathways. Catecholamines, serotonin, nitric oxide, alpha receptors, and muscarinic pathways all contribute. Poor penile erection is mainly treated with phosphodiesterase 5 inhibitors such as sildenafil, or prostaglandin analogues such as alprostadil. Serotonin has inhibitory effect on ejaculation, hence prolongs the intravaginal ejaculation latency time. Hence, premature ejaculation is often treated with SSRIs or other drugs with similar effects. Thus, sexual function is neurovascular, endocrine, and psychological simultaneously. A cross-sectional histology diagram of the penis at mid-shaft is shown. Notice the corpora cavernosum and corpus spongiosum. The corpus cavernosum is particularly important in erection because it contains vascular erectile tissue that fills with blood during sexual arousal. Understanding this anatomy is important for appreciating the mechanism of drugs used in erectile dysfunction. This is the key mechanistic diagram for erectile physiology. Nitric oxide released from endothelial cells and parasympathetic nerves activates guanylyl cyclase, increasing cGMP levels. cGMP reduces intracellular calcium and causes smooth muscle relaxation. As cavernosal smooth muscle relaxes, blood flow increases and erection or tumescence occurs. Phosphodiesterase type 5 breaks down cGMP. Therefore, PDE5 inhibitors, such as sildenafil, prolong cGMP activity and enhance erection. Supportive behavior from the sexual partner is often extremely helpful in managing sexual dysfunction in both sexes. Erectile dysfunction and premature ejaculation are among the most common male sexual disorders. Many myths and unsafe practices exist in society regarding these conditions. Another important point is that androgens are useful mainly in hypogonadism. Testosterone is not a universal treatment for erectile dysfunction. This point is clinically very important because inappropriate testosterone use may produce serious adverse effects and may worsen the situation. If hypogonadism has been excluded, first-line treatment of erectile dysfunction usually involves PDE5 inhibitors such as sildenafil, Tadalafil, or vardenafil. Alprostadil may be administered through intracavernosal injection or intraurethral routes. Apomorphine was historically explored but is now largely obsolete because of emetogenic effects. The key principle is that erectile dysfunction treatment depends upon preserving or enhancing normal physiological erectile pathways. PDE5 inhibitors selectively inhibit phosphodiesterase type 5. Sildenafil is the prototype drug, whereas Tadalafil has a much longer duration of action. These drugs enhance erection only in the presence of sexual stimulation because nitric oxide release must first occur. Therefore, they do not produce spontaneous erections in the absence of arousal. An intact pelvic parasympathetic pathway is essential for efficacy. Adverse effects include hypotension, vasodilation, priapism, and visual disturbances. The visual effects occur because sildenafil may also inhibit retinal phosphodiesterase isoenzymes involved in color vision. Papaverine and phentolamine are injectable vasodilators used in erectile dysfunction. Papaverine is a natural opium alkaloid and vasodilator that causes smooth muscle relaxation through non-selective phosphodiesterase inhibition and calcium channel blockade. Phentolamine is a non-selective alpha-adrenergic antagonist that also causes vasodilation. These drugs directly relax cavernosal smooth muscle and increase penile blood flow. Injected vasodilators are generally not first-line therapy because intracavernosal injection is uncomfortable and invasive. However, they may still be useful in erectile dysfunction secondary to autonomic neuropathy, especially in diabetic patients. Important adverse effects include priapism and Peyronie's disease. Peyronie's disease results from fibrosis of the tunica albuginea, leading to kinked, painful and abnormal erections. This highlights that even highly effective local therapies may carry important anatomical complications. Alprostadil is a prostaglandin E1 analog, which directly relaxes cavernosal smooth muscle and increases penile blood flow. It may be administered through intracavernosal injection or intraurethral pellets. A major adverse effect is priapism, which represents prolonged erection which becomes painful with passing time. Priapism is a medical emergency because prolonged ischemia may permanently damage erectile tissue. Premature ejaculation, also called early ejaculation, is a very common condition. It is defined according to DSM-5 criteria as ejaculation occurring consistently within 1 minute of vaginal penetration with penis, over at least 6 months and in most sexual encounters before it is wished. This condition may produce major psychological stress, relationship difficulties, and performance anxiety. Understanding the formal definition is important because many patients incorrectly believe they have pathological premature ejaculation despite having normal intravaginal latency times. Distribution of intravaginal ejaculatory latency time in the general population is given here. Notice the wide variation among individuals and skewed data. Mean value is often misleading. The median value is approximately 6 minutes. This graph is important because it helps normalize variability and reduce misconceptions. Many patients presenting with anxiety regarding sexual performance may actually fall within normal physiological variation. As mentioned above, SSRIs are commonly used in premature ejaculation because serotonin inhibits ejaculation. Drugs such as paroxetine, fluoxetine, dapoxetine, sertraline, and citalopram may therefore prolong intravaginal ejaculatory latency time. Tricyclic antidepressants such as clomipramine and imipramine may also be useful. This chart is based on data in clinical literature, and compares efficacy of different drugs and distinguishes daily dosing from on-demand dosing. Dapoxetine is particularly interesting because it is specifically designed for on-demand use before penetrative sex. This chart demonstrates another example of psychopharmacology being repurposed for sexual medicine. A comparative summary table is presented here. Paroxetine appears to produce the greatest increase in intravaginal latency time. Sertraline and fluoxetine are also highly effective. Dapoxetine acts rapidly and is therefore useful as an on-demand therapy. The table also highlights important adverse effects such as nausea, drowsiness, insomnia, dizziness, and sexual dysfunction. To conclude, male infertility and sexual dysfunction are common and multifactorial disorders requiring integrated physiological and pharmacological understanding. Perhaps the most important principle is that reproductive pharmacology should always remain individualized and mechanism-oriented. Careful history, examination and a holistic approach often is sufficient to make a diagnosis. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!